This is Call the Psychiatrist, the show where psychiatrists answer your questions. I'm Dr. David Hanley.
And I'm Dr. Abby Snavely.
On today's episode, we'll be answering a question about how to break up with your psychiatrist. And then I'll set the record straight on electroconvulsive therapy.
Say you like me, you better count the ways. Side to side, move your hips.
Okay, before we get started, I have to read a disclaimer. Abby, you were pointing out there's a lot of people online who say ridiculous things, giving horrible advice that people follow, and they seem to do it with impunity. Are we held to a higher?
We're special.
Yeah, I know. Are we just held to a higher standard, or are we paranoid?
Well, we are actual professional people with licenses. So
okay.
Kind of we should be held to a higher standard.
I just think the disclaimer insults people's intelligence, you know? I guess there's just people out there that'll sue because they heard something on a podcast. I don't know.
I think that probably not very many people are going to listen to it that carefully.
The disclaimer or the podcast?
Great question. I hope just the disclaimer, maybe the podcast. I don't know. It maybe is also insulting to the listeners, but giving us too much credit that people are going to hang on our every word.
Right. All right.
If you guys don't like what we're saying, just Google it. You'll get a different answer. It's fine.
All right. I have to say it. So listen up. This is a podcast. Just because you're listening to this podcast does not mean we have a doctor-patient relationship. Our intention is to educate and entertain you. Nothing we say is intended or recommended as a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your own physician or other qualified health professional regarding any medical questions or conditions. All right. So, before we get into the question, we're introducing our segment on feedback. But we haven't actually released anything yet, so we don't have any feedback. So I thought maybe we should have a moment of self-reflection. Is that all right?
Absolutely.
Okay.
You first, though. You first.
So I listened to the last episode, and I rhetorically asked the question if I sounded like Bob Newhart. Okay, so after listening, I think the answer is yes, if Bob Newhart had just smoked a ton of cocaine. I'm going to try really hard this episode. Were you a little
jacked?
Yeah, I mean, I didn't think I was. So I'm like, I guess I talk like that all the time. So my goal today is to take a few more breaths, more frequently than like every 3 or 4 minutes. And if I get pressured, you just tell me to rein it in a little bit.
I will. I mean, there should probably be deep breathing breaks. It's okay. Everybody should do that.
I mean, I got to get this down if I'm ever going to be allowed to read ad copy for a mattress company.
I got to listen to it after you had edited it, and I thought I sounded like a genius. I thought it was incredible.
Yes, that's just true. Yeah, that's just true.
Okay. Yeah, I'm sure you didn't even really have to edit my segments that much.
Exactly. All right. Should we move on to our actual question?
We should.
All right. So we have a question from Jyoti.
Hi, my name is Jyoti, and I've always wondered, how does one break up with their existing psychiatrist or therapist? Sometimes it just doesn't feel right. Sometimes I feel like there's a consequence if I break up. And I guess I just wanted to know what the parameters are around breaking up with one's psychiatrist or therapist. Thank you.
All right, Abby. So how do you break up with your psychiatrist?
Well, it's like any other relationship. So you should
you stop calling back.
Them.
And
block them on all social media and turn the other way if you see them in public, right? Something like that. I don't know. Neither you nor I have dated in a long time, but this is how I hear it goes.
Right.
I think a lot of this can be like any other relationship. I would probably add another part to it that it would be hopefully how we would break up as our best and healthiest selves with good and healthy partners, right? So a lot of what we're going to talk about maybe depends on the therapist being a good faith actor in their half of the relationship, which I hope they do. Hopefully, as this show goes on, people will hear me say over and over that the answer is always to talk about it. So ideally, and not even ideally, anybody's therapist or psychiatrist owes them a respectful professional conversation if the patient wants to end the therapy. That being said, if someone feels that the relationship is not safe or something inappropriate or unethical has taken place, that is actually a time when I think it's fine to be done and ghost, and you don't owe that person anything, or the patient doesn't. But in a mutually respectful relationship, hopefully the patient and the therapist can talk about it. I would like to think that someone can come in with their concerns. I will also point out that, all therapists, our goal is to have the therapy come to an end, right? I mean, my job is to help someone to a point where they can continue to go on and live their life and deal with their own problems without me one day. So in some ways, it is a desired outcome, even if it can be bittersweet on both ends. And then, I mean, I guess some of the questions about how you do it, depends on the situation. Does a person feel like they have just grown enough and they're ready to move on? Do they think the therapist is not helpful? Is something not going well? Do they not feel like they can discuss certain things? And in the case of those last few, where someone's not necessarily where they want to be, but they feel like it's just not happening how they want to or as quickly as they want to, those kinds of issues maybe can be worked through. That maybe a patient and a therapist can better get on the same page, or realign the goals and get back to work. And then, on the other hand, if there is an impasse or if someone needs to move on for whatever reason, again, I think there can be a respectful conversation. And I also want to point out that this doesn't need to and probably ought not to happen just in a single session, right? That therapists do take these relationships seriously. There are parts that are like all of our other relationships and parts that aren't, but someone showing up after a long treatment and just saying I'm done, or ghosting for that matter, feels pretty bad. And then there's always the part of if this is a reenactment, or if the feelings that the patient is having about the breakup, quote unquote, remind them of other aspects of their life. But before we get to that, Dave, I wondered if you had any other thoughts or questions.
No, I'm most interested in the enactment part.
Okay.
Yeah, I think that's the very interesting part that, and it gives some insight into how we think that dynamic therapy even works.
Yeah. Okay. Agreed. So, when I say that, if someone is feeling like they need to break up with their therapist, again, hopefully they're talking with their therapist about it, but all different scenarios could be happening, or it's worth thinking of different ways that this might be reflecting something that has happened in a patient's life before, or does this reflect a relationship pattern? For example, is it actually that the therapist and the patient are becoming close and that the patient fears the intimacy or the closeness and therefore wants to run away? Is it that the person is facing a breakthrough or actually getting close to dealing with something in their life that would, enable them to move forward? Or is it going to force them to make some big changes in their life that they're afraid of? I think, Dave, you had an example. Is it really not working, but the patient is also feeling guilty about it, right? You brought up that people will do this with their hairdressers, right? Like, you don't like your haircut anymore, but you keep going back because you feel guilty in some way. Like, obviously there's something that's going on there that's not just about, the quality of the haircut or the quality of the therapy, that there is some relational dynamic that's getting repeated, which again, in psychodynamic or psychoanalytic therapy, the kind that I'm most trained in and practice the most, I am looking for behavioral and relationship patterns, including around endings, and maybe especially around endings, because I think that so often, if not nearly always in quote unquote real life, people don't discuss the end of their relationship. It fades away, sometimes a friendship, sometimes something else. And often that is socially acceptable. But I would even make a pitch for this being a special opportunity to have a different type of ending with one's therapist, one where you actually get to talk about all the aspects, good feelings, bad feelings, talk about what you've gone through together. Sometimes even after the end of a good treatment, well, actually always, even after the end of a very good treatment, there's going to be things that are left unsolved, unanalyzed, problems that are still with the person. Both the therapist and the patient can, maybe mourn or grieve that, or at least acknowledge the things that weren't gotten to or weren't taken care of. And that I think it can be a pretty special opportunity for two people to really understand what they've gone through together before it officially ends. And I think that that's actually something that can be a real gift of therapy, even at the end. And earlier, when I was saying, I hope people don't just end it in one quick session, I think that's what I would offer up, is that the work is happening ideally all the way up until the end. And if both parties are open, I think that's a pretty unique and potentially healing scenario.
Yeah, I mean, I think you've said everything, which is you're going to break up with me the way you break up with other people. But this is an opportunity to actually pay attention to how that process goes. And you might learn something more about yourself so that you don't have to keep enacting these endings with other people, especially, I mean, when they hurt you in some way, if there's some pathology there. The specific example used, I thought was really good, which is, perhaps you're somebody that shuts a relationship down before you get hurt. Like you end it, or you try to lash out or hurt them before you're hurt. And so it's very possible that you'll do that with your therapist, but you don't have to. That's the beauty of the relationship, is that you can actually look at that together, because it's supposed to be different than all the other relationships you've had.
All breakups are hard, right? Even when it is mutually agreed upon, an amicable divorce still sucks. That's not, I guess maybe a marriage, people go in thinking it's going to be forever. And again, hopefully nobody is going into therapy thinking it's going to be forever, but that there are fantasies in that can be explored. I guess, one thing I wondered about though, is I'm really talking about or making a pitch for when things are more ideal, or that the relationship has gone really well. It's just time for it to come to an end. I don't know if you had other things to add, if it's less of a good therapy or more of a bad fit sort of.
Yeah, I guess that's how I was interpreting the question, that it wasn't necessarily, it wasn't the end of an ideal relationship, because as you're saying, everything has to come to an end, and there's immense power and healing and growth that happens during that process of termination. I'm thinking more of I got to get out of here. And it may be, and you already said this though, it may just be like, yeah, that's the right answer. Like, this person's a creep, or I'm not getting anything out of it. Although even with that statement of I'm not getting anything out of it, I think that bears a discussion. I'm leaving because I'm not getting anything about it. Well, what are the impediments? Maybe the therapist needs to change tack. Maybe they're using a certain set of approaches or theory that just simply doesn't resonate with you, and they have other approaches that they could try, and that would be a discussion. And back to your mantra, talk about it. I think that's true. And I think as long as you're with a good therapist, that's not a conversation that should cause any defensiveness on that person's part. They should be able to talk about it transparently, like what's working, what's not, what can change. And it may be that you both decide that it really isn't a good fit, but I think there's so much to be learned in that discussion about why it's not a good fit. And also, I want to acknowledge that we're talking about like our current practice, which may be unlike how other people experience their psychiatrist. I mean, we're in, we're working individually in a private setting. In other words, there's a lot of times when you're going to be seeing a psychiatrist or some other kind of psychotherapist in a situation where you don't have a choice. Like, it's not a limitless supply of people that you can choose from, and you may be stuck with each other. Again, though, I think there's value in just acknowledging where it's not working, but also still maybe talking about the alliance that you do have or the elements where it could still work. I guess just it's okay to examine the blind spots. Like, nobody has to be upset about that, as you're saying.
And because it is a real relationship, I am going to probably be disappointing, right?
Right, exactly. Yeah,
because I'm a real person in a real relationship. You know, in some ways I of course I'm going to be always doing my best, but that's when you learn. Sometimes I'll know I messed up, but sometimes I'll never know I messed up unless someone tells me.
Yeah. Which, again, such an opportunity for the person, because many relationships don't operate that way. So it's, again, back to the dynamic nature of the relationship. That's part of it, is examining the relationship with your therapist all the time in that particular kind of therapy. I know I keep qualifying things, but I don't want this to sound so foreign to anybody.
Right. And if if someone is seeing a therapist for 12 sessions of CBT to get rid of their panic attacks, and then their panic attacks are gone after 12 sessions, then maybe you're going to be sad a little bit to say goodbye because this person was so helpful to you. But that is much more likely to be an unconflicted, like, yay, we won, we did it together. And it was, a preset period of time and we did it, right? Or if your insurance says you only have so many sessions, you may have to start talking about the end at the beginning, right? I know we only have 20 sessions because that's what your insurance will pay for. Let's try to figure out how to get the most out of it. But the end is going to be present probably in both people's minds from the beginning. And that is a different setup.
Yeah. Which, remember, we had a supervisor that loved brief therapy because all the work was done in the termination. So yeah, you start talking termination on day one. So you just started
right there, right? It's like, nice to meet you. Let's talk about how we say goodbye.
Let's talk about how sad it'll be when we can't talk again.
I know.
But again, I know that sounds ridiculous.
It is. It's so painful, but it's kind of true.
Yeah. And I know that sounds bizarre, but it's because so much work happens there at the end. Like, because you're trying to make sense. Yeah.
And I mean, I guess the other personal part, which I know it's not supposed to be about me, but sometimes I have been ghosted and I have all the feelings that a person would have, right? Like, I'm sad, I'm confused, I wonder what I did. I'm not going to drive by somebody's house playing a mixtape or whatever.
Just look at your Google reviews. I'm sure they'll explain it on
That's
there
right.
with your 1-star review.
My 1-star review is a person who never even met me. But anyway, that's fine.
They could just tell.
They could just tell. They could just tell. It says mean people. I was actually out of town. Anyway, they could just tell. Anyway.
Is there anything else to do in this question for Jyothi?
I think, Jyothi, the answer is you got to talk to them. And if they don't give you an answer, get out of there. And if they do, get everything you can out of it, right? Talk and talk and talk and talk. Is that the outtake?
And don't let them blame you.
Yeah. Good point.
I mean, if they do, then your intuition was 100% correct. You should be out of there.
That's right. Solved.
All right. Well, let's take a very quick break, and when we get back, we'll talk about shock therapy.
Cha 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 cha.
If you or a loved one are having thoughts of suicide, please call the National Suicide Prevention Lifeline at 1-800-273-TALK. You can also chat online at their website, suicidepreventionlifeline.org. All right, we are back, and I'm going to talk a little bit about electroconvulsive therapy. It used to be called electroshock therapy. This is a procedure where electricity is applied to the brain to get a seizure. So ECT actually is still a little controversial outside the medical community, although I will say within the medical community, it's very much accepted as a safe and effective treatment for certain severe disorders. Each state has regulations around its use. And it still has this reputation that it's a treatment of last resort. I brought it up because, I think there are people that don't know that it's still a treatment and thought they might be curious about it. I was consulted not too long ago on a patient admitted on the medical floor. And part of my recommendation was that if things didn't get better pretty soon, that we may have to consider something like ECT. And the resident physician I was talking to was actually shocked that it was still something that we did. So there's even somebody in the medical community. And I've even had patients and even just acquaintances ask me about it just out of curiosity. Have you had that same experience where people are not even sure that we still do it?
Oh, yeah, absolutely. I think, and you'll probably get into this, I think for many people, their kind of only touch point or reference point for it would be One Flew Over the Cuckoo's Nest, right? With Jack Nicholson and it being presented as this kind of barbaric therapy.
Which it had been, but definitely by the time
it had been.
But by the time that book was written, that was not an accurate representation.
No, that's fine. I mean, but I think that the idea that this is a modern day treatment, being done in medical centers and something that has any sophistication to it at all, I think doesn't enter people's minds at all, even if it happens. I think that maybe there's a couple famous people who have had ECT or shock therapy, but even as I think so many parts of mental health care, therapy have been destigmatized, I don't think that there's been much in popular culture to destigmatize this particular treatment, even though, as I know we'll get into, it's incredibly effective and kind of one of the most miraculous things that psychiatry has to offer, in my opinion.
Yeah, if you've got the right patient selection, and you're right, I think it's still not destigmatized because it is still relegated to the most severely ill people. So, right. I was trying to get a sense of how often or what the prevalence currently is, and that data is hard to come by. We do know that it's been declining over the last couple of decades. There was one estimate that only 1 in 10 psychiatric hospitals even offers it. It's kind of expensive, at least in the short run. And so I don't know if there's any insurance pressure as far as not to offer it. I do know that the United States, the overall use is much less than in, say, Western European countries. You had brought up that there was regional differences within the United States that you had noticed.
Oh, yeah, absolutely. That's a great point. So when I was in medical school, I did an away rotation in Chicago where ECT was being used much more frequently, and specifically at one of the hospitals, they had a ECT clinic for pregnant women where people could come in and do ECT for acute treatment, but also for maintenance treatment. For some people, that can be seen as more desirable in that, it's only the risks of the anesthesia. I know we touched on this in the pod last week, but the exposure to the fetus, you're not exposing a fetus to psychotropic medications, things like that. And then I remember coming out to Colorado and hearing a prominent psychologist give grand rounds on depression treatment and pregnancy, and basically saying that, she could never imagine that someone would give ECT to a pregnant woman, even though, it kind of shows up on all these lists.
It's always the answer on any standardized test. If given the option of a pregnant woman, you always do ECT. That's the correct answer.
Right. Or an elderly person, right?
Yes, yes. It's
yes.
D.
Yeah, which is an
ECT.
Interesting thing. D. There you go.
So part of the regional differences probably has to do with state legislation as well. In some of the data sets I looked at, they had a hard time. So when they talked about the West, there was one state that actually drove down the numbers so much that it appeared as though it was almost never offered in Western states. I think they were talking about California. And California, at least it used to be, you had to have 4 different opinions. You had to have 4 different physicians.
Oh, wow.
All consult that you, in fact, were eligible, even for somebody with capacity to make decisions. In other words, they could engage in their own informed consent.
Is that framed as like a patient's rights issue, or what do you think that's about?
I think that's in response to the horrors of ECT and the anti-psychiatry movement. So speaking of the past, I'll segue. Let me give a little bit of history and a little bit of background on this. And I'm sorry, I can't talk about anything without a little bit on history. So I hope it doesn't run
That's
long.
why
I'm
you're
going to go.
here.
I know. I'm going to be light. I'm going to go light on the history, and we'll see what happens. So,
Okay, great.
We have to go back to the 30s. Around that time, we get this surge of medical interventions to hopefully treat psychosis. I'll skip narcosis, sleep treatment, and jump right into the hypoglycemic coma, which was first used in 1933, just a little over a decade after insulin was discovered. So that involved administering insulin to somebody to drop their blood sugar enough that they would go into a coma. So it actually worked. It worked better than the other options they had at the time. And it was so popular, in fact, it continued to be used up until about the 60s. Now, in that treatment, though, if a person sees, that actually was not good. That didn't portend well. But at the same time, there had been some theory that seizures may help psychosis. In that same decade, it was discovered that a drug that's very similar to camphor, which is the same stuff in your Vicks VapoRub, by the way, except injected into your body, could cause a seizure. Speaking of Vicks, I remember I was an anxious enough parent that the first time I put Vicks on my kid, I was thinking like, yeah, I don't know, camphor causes seizures. I mean, if I'd made her eat the whole bottle, it was one of those irrational ideas, but it was still like, I guess that speaks to my parenting style. Like, let's put it on your feet first, but so you don't overdose on camphor.
Max neurosis all the way.
Yeah, exactly. That's me.
Mm-hmm.
Which also, camphor was used in the 1700s, but for some reason to people with psychosis, that information seemed to got lost for a couple hundred years. But anyway, so there were some synthetic drugs similar to camphor that could cause a person to have a seizure. In the United States, that was metrazole, and it was effective, at least in the short term, but it was pretty unreliable. Like the seizures were unreliable. The side effects were atrocious. Patients were terrified of it. But I guess the end result of that was we established that something about seizure seems to be helpful. And so in 1938 in Rome was the first time electricity was used to induce a seizure in a human. And then that technology spread very quickly, at least throughout Western Europe, and then finally into the United States. It took a little while to get a foothold in the United States because we were so mired in the psychoanalytic model of mental illness that this was felt to be a huge challenge, to the theories and the underpinnings of how mental illness, what the cause was, what the treatment should be. And so introducing this notion that this biologic intervention or medical intervention could help someone was not welcomed. And so it took a bit more time to get established here. So we talked a little bit about the brutality early on, and I think that's true. I mean, the side effects were severe. These were incredibly strong seizures. Patients often broke their teeth. They got broken vertebrae. Because of this, though, that actually introduced curare into the medical world, and so that's a paralytic agent. A similar analog is succinylcholine, which is still used now. If you've had surgery, you've probably been given a paralytic drug so that you're not flopping around on the operating table. And so those drugs were used then in ECT, so the patient wasn't actually having a motor seizure. And then shortly after that, they were actually given general anesthesia, which led to a much better experience for the patient in terms of tolerating the procedure. So the height of ECT was around 1959. It was clearly the treatment of choice for severe depression and psychotic mania. And this would be in spite of the rise of pharmacologic agents. But then the 1960s hit. There was these two big events. You mentioned one. Ken Casey's One Flew Over the Cuckoo's Nest actually was published in 1962. The other thing that was going on, though, and Ken Casey was part of this, was the anti-psychiatry movement, which, among other things, said that mental illness didn't actually exist. ECT was just used to punish people. And that really took hold. The other group in the anti-psychiatry movement that was incredibly effective was Scientology. they were able to get a number of states to pass legislation that would outright ban ECT. Now, those laws didn't go into effect, but I think that tells you how effective they were at changing the practice. It was so effective, in fact, that ECT pretty much disappeared completely from university programs from 1960 to 1980. And then finally, 1985, the National Institute of Health puts together an expert panel that ultimately restored ECT in the medical community.
How did it come back, though? Like, there was the panel. What was the movement to make that panel happen?
Yeah, part of the resurgence really has to do with I'm going to say the death of psychoanalysis, which I know, you have extensive training in psychoanalysis, but on a grander scheme and a philosophical scheme, really as the pharmaceutical industry was taking off, and then the hold of academic institutions through the analyst was fading, there was this reinterest, of course, in this biologic model of mental illness, and along with that, ECT caught those coattails, and people were interested. And I don't, the negativity that was in the society or culturally was never particularly adopted in medicine. It was really just,
Right.
I think it's an interesting and maybe unfortunate part of the history of psychiatry is how intimately tied it is to the culture, pop culture, politics. And so I think the political winds had just shifted enough that they could start having that discussion again. Because it wasn't like there were a ton of studies to revisit. It was really about expert consensus. Once enough smart people got together and said, hey, it was actually working okay. These are the outcomes. And it was working better than anything else we have right now, despite the last 20 years of drug development.
Well, and I would have to guess that there were plenty of people that were suffering extreme disability or death because of their mental illness, right? I mean, that we know that these illnesses can be, again, life-altering, disabling, deadly. And it seems like if you didn't have this, potentially life-saving treatment at your disposal, that's pretty bad for your patients.
Yeah. I mean, we should talk about why it's so unsatisfying. And one reason is because we don't know how it works. I mean, that's not very scientific. There's a lot of theories, but ultimately they all sound a bit thin. I mean, people are kind of grasping.
So like, treat it like a reset button on your brain, right?
Exactly.
Then you're like, I don't know, comparing somebody's brain to a computer.
Right. You're rebooting it. Just reboot it. Pull the plug on it.
Right.
And
Just
plug it back
reboot it.
in.
Just
right.
push the, hold the power button for 5 seconds, something like that.
It's very unsatisfying.
You're right.
Yeah. And I've always thought about it as there's this amazing organ that we know the least about, and you just got to come in with a sledgehammer and you're like, give it a couple of good, or God, this would be an old reference again, but pounding the back of a television, to get it working again.
Sure. We've all done that. Tape deck in your car, something.
Yeah. So there has been more research in the last 40 years, though, since the reboot, which has showed some good outcomes using less voltage, using high frequency pulses, and only doing one side of the head. So there are still some cases where psychiatrists recommend that the electrodes are actually applied on both sides. But the idea is that if you could apply the electricity on one side, you actually may help preserve more memory. The memory loss, either before or after the procedure, might be better preserved. So, yeah, I think, we talked about how the procedure as represented, or how as people probably remember it, is not accurate. So we should probably talk about what it actually looks like. So I'll just be kind of brief here. You go into a waiting area, you get an IV, you go into the procedure room, you're given an anesthetic, not that unlike what you might have as far as conscious sedation, getting a colonoscopy or something like that. You're then given the paralytic medication. And then in that brief moment, the electricity is applied, medications are given to make sure your heart rate and blood pressure don't go up. And something that's kind of interesting, because the muscles are briefly paralyzed, you inflate a blood pressure cuff on either the arm or the leg right before the moment that the paralytic drug is given, or the muscle relaxer, so that you can monitor the motor seizure that's happening, the actual tonic-clonic movements. So in other words, the seizure itself only appears to be happening in a hand or in a foot. So it's not the full body thrashing or anything like that. The patient recovers pretty quickly, 30, 45 minutes, wakes up, has some juice. They might not have any memory of the procedure itself. They might even have difficulty remembering the rest of that day. But often then they go home or, unless they're currently in the hospital. And a typical treatment is about 12. And those are usually 3 times a week for 4 weeks. There are some people that need maintenance. They have to go back, and that seems to be the only thing that might keep them functioning and keep them healthy. But other people, it seems to resolve. It all depends, of course, on what you were treating to begin with. So, yeah, I think my take, which you alluded to earlier, is that it works really well if you've got the right patients. I do think that it gets overused. Now, I just said it's on the decline, but I still think even in that population, it gets overused sometimes for the wrong diagnoses, and then it's underused for the right diagnoses. So that's my critique, I think, overall.
Can you elaborate on that? I guess I can say what I think is the, right diagnoses. I think of an elderly gentleman who was on the inpatient unit who was catatonic, as in not eating, not toileting on his own, not able to take medicine, right? Just basically laying in bed, not interacting, doing no functions of life, who got ECT and within a couple of treatments was, walking and talking, eating, going to the bathroom, telling jokes, truly woken up. I mean, even if, people throw around a word like catatonia, but when someone really, isn't doing anything voluntarily, that's pretty amazing to me. But I don't know what you would say.
Well, I mean, I think the studies on it bears out that, to get the kind of miraculous results we're talking about, it really is the severely ill. And so I think sometimes when I say maybe the inappropriate diagnoses are the people that just don't meet that criteria, they're not going to get the same kind of results or the same kind of level of remission if they have milder, more moderate symptoms. And I'm talking about, obviously, with depression, severe depression, psychotic depression. You mentioned catatonia, particularly in geriatric populations where the side effect burdens of medications are so much more severe that, again, when you're trying to balance those side effects or the risks with ECT, it actually becomes a very reasonable intervention to get those people functioning.
But sometimes people aren't responding well to medications, for example, because of personality disorder or some other issue that's getting in the way of first-line treatments doing what we might want them to do.
Yeah, and a lot of referrals get made because, nobody knows what else to do. It's not saying that the person's not suffering or that it's a difficult treatment course and all their providers are frustrated and they've been through 5 therapists, and it's like, well, just go do ECT. And it's like, yeah, that's probably not going to be the answer either. And I think that's what I mean is sometimes those in our system, those people end up doing it, and they may even want it sometimes for other, motivations. But those aren't going to be great outcomes. And then I think all they're really going to then experience is the negative parts of it, the side effects and things. And now they have something else to battle with, like I don't feel any better, but now I just have amnesia for the last couple of weeks. So, so thanks.
Okay. Thanks. Thanks for nothing. Thanks for not helping me again.
Yeah, exactly. That was really expensive though. All right. Well, I think that's it. Thank you so much for listening. We really want to hear from you, so please send in your questions. You can email us a voice memo or a regular email at callthepsychiatrist@gmail.com. You can call and leave a voicemail at 760-779-2477. That's 760-PSYCH-77. Please help us out by subscribing or following this podcast in whatever app you use to listen to podcasts, and please tell a friend about our show. Also, you can join our Facebook group where we can interact and you can ask your questions there. And finally, leave us a rating and review so others can find the show. Let's talk soon. Take care.
I get why you're making all the caveats. Every podcast I listen to acts like CBT is the only kind of therapy that's out there happening. I mean, they're not psychiatry podcasts, right? But like the host is like, oh, I love my therapist. I finally got into CBT and I'm so glad I don't have somebody who just wants me to free associate anymore. Like I got a real therapist. And it's like, bitch, that's not the only way to do it.